So I'm going to give a talk on valve-in-valve sizing and procedural considerations. So with that, let's start understanding that it's a Class 2A recommendation, benefit greater than risk for valve-in-valve procedure. 30% of the valves degenerate due to regurgitation, 30% are combined, and 40% are aortic stenosis. The rate of valve degeneration is well obvious to everybody. We understand that. What is the data on valve-in-valve? Approximately 7.6% mortality at 1 month and a 93% survival over a period of time. Overall, a great survival of 82% over a year. So I think it's an established procedure now, and further recommendations would establish it even with a greater strength. The earlier the valve is implanted, the more it degenerates. The average life of a prosthetic valve is on an average of 15 years, but we must remember that the earlier in age its implants is, the more rapid the degeneration of the prosthetic valves. Various issues do happen with these valves. It are wears and tears, calcification, pannus formation, clearly endocarditis and thrombus formation are the various mechanisms. So understanding the valve itself, there's no standardization of the valve size labeling across the industry, and that's rather an irritant, should we say, because what the label valve size is typically relates to what a valve size can actually be inserted into the patient, and relates not to the inner diameter of the valve, but to the base ring of the valve. It doesn't even relate to the sewing ring. It relates to the ring which is inside the sewing ring, and that's the size of the valve. What we are interested in is the inner diameter, and I think that's important to understand.